Inserting a nasogastric tube for patients with head and neck cancer is very important, especially if patient suffers of malnutrition. Apart from head and neck cancer, patient might need feeding in acute stroke, when 50% of patients after stroke are unable to swallow properly. There are severe maxillofacial traumas or abdominal traumas when the patient needs feeding. In certain neurological disorders, we need to feed the patients, and also children need to be extra fed in developmental problems. There are certain disorders when there is a hypercatabolic state, especially after severe burn, when the patient needs also extra feeding. When we want to do a decompression for patients with diabetic gastroparesis, we might also need feeding tube inserted for the patient. And there are other certain special cases when a nasogastric tube needs to be inserted. Patients with head and neck cancer often suffering of malnutrition due to alcohol consumption, tobacco use, and poor diet. Also, their cancers cause patients dysphagia or painful swallowing and different smell and taste disorders besides aspiration. The tumor itself causes hypermetabolism, and as such it will increase protein catabolism. The surgery that we perform on head and neck cancer patients also causes some pain and aspiration besides the altered anatomy which prevents patients to swallow properly. The additional radiotherapy, chemotherapy have side effects such as mucositis, pain, edema, nausea, and dryness of the mouth. All of this will cause a protein calorie malnutrition for the patient, which is progressive, and it will cause a depletion of protein and fat storage in the patient, and together all the above will cause the patient to lose weight. Basically, there are two ways to provide nutrition for patients. One of them is parenteral feeding or parenteral nutrition. In this case, we give nutritional formulae containing nutrients of salt, glucose, amino acids, vitamins, and minerals to patients, usually through a central vein. This is also called total parenteral feeding. The other way to provide nutrition for the patient is enteral feeding. When gut works, we should use it. So in normal gastrointestinal tract, we should provide food into the gastrointestinal tract, either in the normal way, so per os, or through nasogastric or other feeding tubes, or through different type of stomas. So in case we provide extra foods through the oral cavity, it is basically a type of enteral feeding. In this case, we give supplementary nutritional diet for the patient. There are tube feeding types. Tube feeding means that we insert a feeding tube, to the gastrointestinal tract. The most often we use a nasogastric tube. Other type of feeding forms are through stomas. We can create openings to the gastrointestinal tract and provide food through these openings, through these stomas. The traditional gastrostomy is the open surgical one. It is either done in general anesthesia or in local anesthetics. More often we do percutaneous endoscopic gastrostomies. In this case, we create a stoma to the stomach through the abdomen. And we can do this with the aid of endoscopes. But we can also use to create stomas, percutaneous gastrostomies, with the aid of an X-ray, ultrasound, CT or MRI guided, or even laparoscopic. Nasogastric tube feeding is one of the most common form of tube feedings for short term. Nasogastric tube is a silastic tube, and the bigger the diameter, the easier to use for feeding. There is a colored longitudinal line on the tube which is radio opaque. It serves to visualize its position by an X-ray. You can also see horizontal colored lines on the tube. A single line marks the length of 45 centimeters. A double colored line marks the length 55 centimeters. And the triple line marks 65 centimeters. When we insert the nasogastric tube through the nose, we might use some local anesthetics and decongestant sprays to the nose. However, without any anesthesia, it is easy to insert a nasogastric tube. The end of the nasogastric tube should be lubricated. Usually we use lidocaine jelly, and it should push through the nose into the pharynx and down to the esophagus. We usually use the wider nasal fossa. The patient should tilt the head forward, and we ask the patient to swallow while we advance the nasogastric tube through the nose down to the esophagus. In case the patient starts coughing or choking, then it is the sign of misplacement of the tube. Usually, in these cases, the tube enters the trachea. In this case, we should withdraw slightly the tube and ask the patient to swallow again and push down the tube when the patient swallows. We should advance the tube until the double horizontal line, which should reach the nasal entrance. This would mean that the end of the tube is 55 centimeters away. It is usually at the site of the cardia. We should control the correct position of the tube. There are several ways to do this. The most common way to do this is we blow air into the feeding tube with the feeding syringe and listen with a phone endoscope over the patient's stomach. If we hear air bubbling into the stomach with the stethoscope, then the tube is in correct position. We can also use an X-ray to make sure that the tube is in correct place. The longitudinal colored line on the tube is radio opaque, and it would show nicely on the X-ray. The third way to check the correct position of the tube is to aspirate some fluid with the syringe from the tube. If the pH of this fluid is below 5.5, then the tube is in correct position. We should fix the tube to the nose with a tape. The ideal position of the feeding tube is above the cardia and not through it, since it can cause reflux. We should pull slightly the tube back in case of heartburn or any other signs of gastroesophageal reflux disease. Nasogastric tube serves for short-term feeding. We should use nasogastric tube in case the feeding need is maximum 5 to 6 weeks. If we need the patient to be fed longer, we should use percutaneous endoscopic gastrostomy. Percutaneous endoscopic gastrostomy serves for long-term enteral feeding. Inserting a PEG is started with the standard esophagogastroduodenoscopy. The endoscopist should inflate the stomach with air to approximate the stomach wall to the inner surface of the abdominal wall. To identify the exact and correct position of the PEG tube, the endoscopist should transilluminate the abdominal wall and also finger push the abdominal wall externally to visualize the indentation of the finger. These maneuvers also ensure that no trapping of organs took place between the abdominal wall and the stomach wall. After marking the correct position of the tube, we should use some local anesthetic to the skin and do a tiny, approximately 1 centimeter incision on the skin, and a needle with a trocar should be inserted through the abdominal wall into the stomach. The inserted needle should be grabbed by a Dormia basket by the endoscopist, and the thread should be led through the needle into the stomach. After grabbing the thread by the Dormia basket, the esophagogastroscope should be pulled out together with the thread. A PEG feeding tube should be tied to the oral end of the thread and basically pulled back through the mouth, through the esophagus, into the stomach and out through the abdominal wall. The PEG feeding tube has an inner bumper which would attach to the inner surface of the stomach and hold the stomach to the abdominal wall. Afterwards, externally, an external bumper placed on the feeding tube. Next, a control second look endoscopy is performed to visualize the correct position of the inner bumper and the feeding tube. Here you can see the instruments and the feeding tubes needed for enteral feeding, both nasogastric tube feeding and percutaneous endoscopic gastrostomy. Thank you for your attention.